Good afternoon, everyone, and welcome to the Lynn Cancer Institute. We'll be hearing today from our physician panel series. Today's topic will be comprehensive care in brain tumors, a multidisciplinary approach. We will be learning from our two outstanding speakers, Dr. Sarabi Ranjan, neuro-oncology, and Dr. Robert Press, radiation oncology, and our new director of proton therapy at the Lynn Cancer Institute. We're very fortunate to have these physicians who work with our neurological cancer patients, experts who are deeply committed to improving the lives of these patients in our community. At the Lynn Cancer Institute, we believe that education and awareness, prevention, screening and early detection, a variety of treatment options, our latest technologies, the expertise of our staff, and as we're seeing today, the benefit of our multimodality method of treatment, all combined will truly help to save lives. In the interest of time, the speakers' bios were sent to you by email. And during their presentation, we invite you to please take notes. And if you have a question or comment, please put it in the Q&A or in the chat box. And there will be time at the end of the presentation for one of the physicians to address your question. So that being said, thank you for joining us. And we're very proud to welcome Dr. Ranjan.
Thank you so much for the kind introduction. I am a neuro-oncologist. I've been in practice for the last 9 years, and I have the honor of joining and serving the wonderful community of patients and colleagues at the Lynn Cancer Institute. So today we are going to talk about brain tumors and honor the month of May as a brain tumor awareness month. And the first thing I would like to say is just why are we doing this? So our slogan is "Go Gray in May," and the brain has gray matter, so we just call it Gray May. That has a connection to the brain, so we have designated May as the Brain Tumor Awareness Month. Our goal is to improve the public understanding of brain tumors and brain cancers to support our patients and survivors. And why do we need that? There is great amount of awareness, and I'm so happy that we see so much awareness about breast cancers and then lung cancers, huge awareness campaign about smoking, against smoking. Then we have great awareness campaigns against melanoma. These are the top 3 or 4 most common cancers in the US. And now you see even public park having sunscreens against skin cancers, melanomas, etc. But there is still a lack of awareness about brain tumors. One of my most common cancer is glioblastoma, and it is my most common disease which I treat. And till date, when I first meet a patient, they have never heard of this diagnosis before until they are actually diagnosed with it. So that is why awareness matters, because the brain tumors are uncommon and they're much rarer than other types of cancers, but the effects can be devastating. And the symptoms are subtle, they're often ignored until sometimes it becomes too late for timely diagnosis and treatment. And when the symptoms are subtle and the brain tumor is well controlled, the treatment outcomes are always better. So that is the goal in our Awareness Month. And this type of ongoing advocacy and research support does a lot for improvement. Just as an example, a similar rare condition is ALS. And there was this ice bucket challenge, and there was so much awareness, and even a new drug finally was funded because of the research and advocacy. So I hope to see a similar effort and advocacy in the field of brain tumors. So, some common facts about brain tumors. They're relatively uncommon in adults, but in children up to the age of 14, they are the commonest type of tumors. So, the medical oncologists in pediatrics, they're very comfortable with treating these tumors, unlike in the adult population where a medical oncologist may not have as much experiences with treating brain cancers. When you come to the young adult population, up to the age of 40, they are the second most common type of tumor, the most common being breast cancer. Um, but they are the sixth leading cause of death from cancer in adults 40 years of age and plus. So the effects can be devastating on patients, societies, and families. um, what is a brain tumor, or what is a tumor in general? So, a tumor is nothing but an abnormal growth of cell in the brain. So, normal cell, our body is a very efficient system and has a very good control against things going wrong. So, the normal cell divides and it makes the final healthy tissue. But when there is a genetic change in one of the normal cells, the rate of cell division becomes uncontrolled. And then the uncontrolled cell division forms a tumor, and that can be benign or malignant. And a brain tumor can be, as I said, benign or malignant, and it can be primary versus secondary or metastatic, which means coming out from some other place rather than the brain, but finding a home in the brain. Common examples of brain tumors are glioblastoma, meningioma, pituitary tumors, brain metastases, etc. Let's look at some difference between primary brain tumors and metastatic brain tumors. So, primary brain tumors start in the brain itself. They start in some type of tissue inside the brain, be it meninges, be it your pituitary, be it your astrocytes or neurons. But the brain metastasis spreads from other types of cancers, and most common being lung or breast or melanoma, etc. Primary brain tumors are much less common than brain metastases. And every year, about like 90,000 new cases of primary brain tumors are diagnosed in the US, but about 250 or up to even 400,000 new cases of brain metastases in the US, which is almost as common as every year number of patients diagnosed with breast or lung cancers. So, primary brain tumors can be anything between grade 1 to grade 4. And brain metastases are generally staged, not graded, and they are stage 4. Some common examples are gliomas, meningiomas, ependymomas, and brain metastases. The most common are lung, breast, melanoma, renal, or now colon is also increasing. Um, so let's get into the one of the common things I hear from patients: grading versus staging. So I just met a patient in the hospital with glioblastoma, and the most common thing which patients hear is it a stage 4? So one thing I wanted to clarify as a neuro-oncologist is that grading and staging are two different things. Staging is a way of describing or classifying a cancer based on the extent of cancer in the body, and then it depends on the size, the extent of tumor, the lymph node involvement, spread to other parts of the body. And then you use the term staging because you want to understand the seriousness of the cancer, how much treatment to plan. Does the patient need only surgery? Will they need some other things like lymph node dissection or some other local type of treatment, or will they need extensive chemo or radiation? And staging is a term used for systemic cancers and not primary brain tumors. For example, we wouldn't call a glioblastoma as a stage 4 cancer because glioblastoma, by definition, being a primary brain tumor, it is localized to the brain and does not spread to the rest of the body. It doesn't mean that it's any good or bad than stage 4, it just means it's different. So, a brain metastasis is always a stage 4 cancer. But in when we're talking about primary brain tumors, we classify it according to grades. And grading is a description of how the tumor looks under the microscope. And for example, a benign brain tumor looks um, pretty close to a normal, but not quite normal under the microscope and has some characteristic features and slow division. So it will be a grade 1, whereas glioblastoma is aggressive and looks very aggressive under the microscope with a large amount of cancer cells. So it is graded as a grade 4. So, for example, my patient is a grade 4 type of tumor, and the word staging is just not applicable to this situation. Now, let's go into defining what is a benign brain tumor or a malignant brain tumor. Malignant brain tumors are also called brain cancers. So a benign tumor usually slow growing, whereas malignant is fast, and a benign tumor has a well-defined localized border, and it usually does not spread to other organs. And benign tumors, unless it's causing problems, sometimes we observe them. If it is causing problems to the patient, like causing some symptoms such as seizures or blocking some important pathway of the brain, then it can be removed with surgery. And benign tumors usually have a favorable outcome, and examples would be meningiomas, pituitary tumors. Whereas in terms of malignant brain tumors or brain cancers, they are not very well defined, and the cancer cell infiltrate or invade nearby brain or nearby tissue. But interestingly, malignant brain tumors, even the most malignant one, like a glioblastoma, does rarely spreads outside the brain or the spinal cord, but causes problem by being very aggressive and causing destruction of the brain tissue locally. And generally for malignant brain tumors, such as start with surgery, then most patients will require radiation, and then they will have some type of chemo, whether it's IV chemo, oral chemo, immunotherapies, targeted therapies, or a combination depending on what exact treatment is. And the outcomes are variable sometimes, but not all. The outcomes are poor, but early diagnosis and treatment invariably improves outcomes. So, for example, glioblastomas and brain metastases are types of brain cancers. Another interesting thing I want to point out is that a benign brain tumor does not always mean harmless. Um, there are patients who can have life-threatening complications if the tumor compresses the critical structures of the brain, such as the brain stem, ventricles, optic pathway, or destroys the speech or motor areas. So, and then benign and malignant brain tumors can cause identical symptoms. So it's not that only malignant brain tumors will cause severe neurological symptoms. So early recognition and treatment also matters as much in benign brain tumors. And in most cases, I would say that brain surgery is pretty safe, and we have come a long way that if indicated for the right reasons, surgery is pretty safe even for benign brain tumors. So wanted to share some key facts about primary brain tumors. There are over 120 different types of primary brain tumors. So even I have not seen them all, or maybe seen only the most common types, maybe like 30 or something, but there are over 120. And we as neuro-oncologists are trained in neurological symptom management, as well as different types of primary brain tumors, given the different rarity and the uniqueness of these. So, our most common primary brain tumors are gliomas and meningiomas. Gliomas arise from the glial cells in the brain, and meningiomas arise from the covering of the brain, which is called meninges. Um, my most common malignant primary brain tumor is glioblastoma, and the most common benign brain tumor we see is a meningioma. And I discussed that there are anywhere about like 90,000 new cases of primary brain tumors diagnosed every year, but 2/3 of these would be benign. So, and only a third of those would be third, or even a fourth of those would be malignant. And outcomes vary. Again, not all brain tumors are doom and gloom. Low-grade tumors can be managed excellently long term. People can have a normal life, family, marriage, careers, everything. And even with modern treatment, high grade tumor patients can have these milestones in their life. This is a picture from the WHO classification. The blue ones, as you can see, the almost 3/4 of all primary brain tumors are non-cancerous. Meningioma, pituitary tumors, some type of nerve sheath tumors, and some non-malignant gliomas. And about a fourth of them, most common being glioblastoma or other types of gliomas, are cancerous. Um, so now let's talk a little bit about symptoms of brain tumors. So there's no umbrella symptom of brain tumors, which is where my training as a neurologist helps me, because the symptoms of the brain tumor depends on where the tumor is located. If the tumor, the frontal lobe helps with executive functioning, planning, personality, decision making, and walking. So tumors of the frontal lobe sometimes cause personality change and falls, and many other symptoms, or the patients to become lethargic or just mild fatigue, whereas parietal lobe functions are to identify objects and your visual spatial orientation and sensation. The temporal lobe helps with memory, short-term memory, hearing, language. You have your occipital lobe, which mainly helps with the vision, and the cerebellum with the coordination and balance. So it all depends on where the brain tumor is situated. And important to know is that a large part of the brain can be non-eloquent or does not directly cause a lot of symptoms. So that's where examination, a good neurological examination and symptom assessment will confirm some findings, because often these quiet tumors would be missed by uh, by many. So most of my patients would present with, sometimes they would, patients usually, because there's so much stroke education, any sudden neurological symptom that the patient appears confused, it cannot speak, they usually are stroke coded and come to the ER. And that's how most of my patients are diagnosed. Um, Sometimes patients will have a new type of headache or change in headache or new onset seizures or worsening of their seizures, progressive weakness or numbness, speech problems, memory problems of infusion, balance issues, or vision problems, which will bring them to a doctor's attention. I've put the headache and the memory loss confusion in red because Those are, in my experience, if patients presents with headaches or they have a history of migraine and then they develop new headaches, um, they're often not carefully assessed and they end up with a delayed presentation. Also, the brain tumors are more common in elderly, especially or over 60 years of age. So many times when patients present with confusion or memory loss, their doctors or family thinks that they're developing some type of Alzheimer dementia or some other types of memory loss, and they present with in a delayed manner. The red flag symptoms I would definitely not ignore and try to get a prompt evaluation is if somebody has a first seizure in adulthood, that definitely requires an urgent MRI. Somebody with a sudden personality change, they have been like go, go, go all their life and suddenly they don't just care. So it's not just, it may, you shouldn't just label it a mental health issue, but it requires a full evaluation before you can call that secondary to depression or anxiety. So persistent nausea and vomiting, again, in the ER, sometimes people get GI medication, a CT of the abdomen, but the problem lies in the brain. Um, Progressive headaches, worse in the morning, or waking patients from sleep, or even suppose somebody has a lifelong history of migraines and suddenly they're getting worse. There's a change in pattern that requires an urgent evaluation. Sudden onset confusion, double vision, or arm or leg getting weaker. These are the red flag symptoms which should not be ignored. Um, Brain tumors are diagnosed once patients get symptoms and they have some encounter with a medical team where they get a neurological examination, which may or may not be abnormal. And then most patients get an MRI. If a brain tumor, if a brain tumor is supposed to be causing those symptoms, that most patients will get a surgical resection or biopsy. And then we have advanced tissue testing, including genetic markers, and we reach a final pathological diagnosis. And that's an integrated diagnosis based on not only the tumor tissue, but also the genetic tests. The good thing is that here at Lynn Cancer Institute, we have a modern, very modern brain tumor team. It's a teamwork, as we all know. We start with the neurosurgeon, who often is the first one assessing the patient. Then neuro-oncologists like myself. We would, for primary brain tumors, I am the one directing most treatment. For metastatic brain tumors, it is the medical oncologist. Then radiation oncology is the most important backbone of our treatment, especially for brain cancers. Then neuroradiologist, neuropathologist, and we have an excellent rehab team right in front of us, the Gloria Drummond. Those are very important for patients' outcome, palliative care, and nursing. So this is a modern brain tumor team, which should also talk to each other for the best outcomes of the patient. Now, diving a little bit deep into gliomas, as I said, gliomas are the most common primary brain tumors. And at first, they were just diagnosed based on how they looked under the microscope. But now we know that there's a very important gene called the IDH, and that determines the gliomas into two different types, IDH mutant versus wild type. And then further, they are classified based on their genetic signature as an oligodendroglioma or astrocytoma. And then patients who are IDH wild type and have certain features, high-risk features such as microvascular proliferation or abnormal growth of blood vessels and necrosis or cell death, and certain genetic markers, they're called glioblastoma, and they're always WHO grade 4. So as you can see, we have a normal brain, and then the brain cells, there is some genetic process going on which causes some changes, and you see some abnormal cells, usually um, uh, not a lot of cell division there. So WHO grade 2 astrocytoma. Then when you see more cell division and proliferation, you have grade 3. And then when you have abnormal blood vessels and necrosis, grade 4 uh, astrocytoma, also called as a glioblastoma. Um, glioblastoma in this brain tumor awareness month, I would like to just show some representative cases. This is our most aggressive and most common type of brain tumor we treat. And as you can see in this patient, the patient presented with a very large right parietal occipital temporal glioblastoma. And right-sided tumors are often diagnosed late because patients do not get a lot of symptoms until it's pretty late. So a very common thing we see in our practice. And you see that the tumor is pretty large as right here, and there is abnormal leakage of contrast around this, and there are necrotic areas which typically look like this under the microscope. The standard of care treatment of glioblastoma is once the patients are diagnosed on MRI, they get a surgical resection, maximum safe surgery, and they get radiation for 3 to 6 weeks, and they get an oral chemotherapy called temozolomide, and then they get monthly chemotherapy for 6 to 12 months, and also they get a device called the tumor treating field. And then we support the patient's journey throughout with palliative care and supportive care. This treatment, so the way we plan treatment is based on clinical trials. The standard of care treatment of glioblastoma is based on this Stoops protocol, which showed that early on when patients were treated by radiation only, their outcome was not that good, but they had improved survival when chemotherapy called temozolomide was added to the standard of care. And it may appear that, the chemotherapy Temodar works and improves survival by a couple of months, but there is a subset of patients which are called the MGMT methylated patients, and they respond well to chemotherapy, and younger patients can live 3 to 5 years even with a glioblastoma. So just talking a little bit about this MGMT. So a third of glioblastoma patients will have this marker called MGMT methylation, MGMT promoter methylation. And when patients have these markers, it's an independent favorable prognostic factor. So patients with this mutation, they live longer and they have a more favorable response to temozolomide. And even patients who are not methylated, they do have an improvement in survival with the temozolomide treatment. The next thing, which was recently added to the standard of care about a decade ago, was this tumor treating field called Optune. So this is, as you can see, is a device where these tumor arrays are worn on the scalp, and they deliver alternating electric field through these scalp arrays. And this low dose direction-changing electromagnetic field disrupts the mitosis and mitotic spindles, which cause cell division. So the cancer cells cannot divide efficiently, and combined with temozolomide and radiation, they improve long-term survival in patients with glioblastoma. And it's something we do here, and also is considered the standard of care treatment covered by insurance companies and FDA approved. Just giving a story about one of my patients with a brain tumor. So this 33-year-old woman presented with a long history of migraines. And she was a social worker, and developed migraines were under control and then started having new headaches and word finding difficulty. Went to the ER multiple occasions, was given the migraine cocktail and discharged. And unfortunately, no imaging was done until a while. And it was everybody just attributed a word finding difficulty to stress at work. And ultimately, this MRI was done, and it showed this left parietal tumor, and she underwent a complete surgical removal and was found to have GBM and GMT methylated, and then treated with 6 weeks of chemoradiation followed by 6 cycles of oral chemo, and also started on Optune and remains on it. And she's doing extremely well after 5 years of diagnosis and getting married this fall. Before I end, I would like to talk about some common myths about brain tumors. Most brain tumors are not hereditary. Gliomas are not usually passed down in families, and only a very small percentage are related to inherited genetic syndromes. And there has been some anxiety about cell phone use and brain cancers, and large studies have been done, including meta-analysis, which have shown no consistent causal link between cell phone use, the cell phone towers, and brain tumors. And brain surgery is obviously a very important decision in anybody's life, but at a good high volume neurosurgical center with modern equipment, brain surgery is pretty safe. And the goal is to do maximum safe resection and to prevent disability in a patient. Not all brain tumors are fatal. I have had patients live a normal life with 30-year history of gliomas, which are also considered brain cancers, but they have lived their entire life, maintained a career, family, children, grandchildren with brain cancers. And head injuries and stress does not cause brain tumors, and that's another myth. I would like to introduce some organizations in our field: the National Brain Tumor Society, ABTA, our great organization which does advocacy and research work. National Cancer Institute also provides a good amount of information on brain tumors. Society for Neuro-Oncology is our academic leading professional organization. And also we have the Glioblastoma Foundation, which help in patient advocacy, research support, and access. So on this note, awareness leads to earlier diagnosis, and research leads to hope. And with compassion, we change lives. Thank you so much.
Thank you for that nice talk, Dr. Ranjan. And to follow up, the second part of this webinar, we'll talk about radiotherapy for brain tumors. So from a radiation oncology perspective, what patients and families should know. So I have no disclosures. Quickly, the objectives of this talk. So we'll just go over what is radiotherapy, what are the different types of radiotherapy and different approaches we use. And how is it used, particularly for brain tumors, which brain tumors. And then I want the audience to understand the workflow, radiotherapy planning and delivery. So from a patient perspective, what can you expect as you're going through radiation? We'll talk about what are the potential side effects of radiotherapy, how we try to mitigate those effects. And then after you finish treatment, how do we monitor for response after treatment? So what is radiotherapy? So it's one of the three pillars of cancer treatment. About 50% of, so it's one of three pillars. So there's, of course, neurosurgery, and then there's medical therapies Dr. Ranjan prescribes, and then radiotherapy. It's a really important aspect of brain tumor treatment. About 50% of all cancer patients will receive radiotherapy at some point in their diagnosis. And in the brain, it's particularly critical modality, given the location, it's a very invasive location to do any sort of surgery on. And often some drugs do not penetrate the blood-brain barrier well. So we do rely on radiation often to control brain tumors as part of the three pillars. And so radiotherapy is high energy ionizing radiation. And you look at the electromagnetic spectrum here of light. So we have, of course, our visible light that we use every day. We have radio waves on the low frequency spectrum we use in our car. And then we have high frequency X-rays that we use clinically to treat brain tumors. And these X-rays have high enough energy that they can cause DNA damage. And so the mechanism of action for this is shown here in this figure. You have an incident photon or X-ray that hits near tumor cell DNA, causes a chemical reaction which releases free radicals, which then latch onto the DNA molecule and cause them to break. And these breaks accumulate over the course of radiotherapy treatment, and eventually, as the cells attempt to divide, which cancer cells do, they have a catastrophic mitosis or division and die off in that time. And this is how we use radiation to control tumors over time. So what types of brain tumors are treated with radiation? Well, basically the whole list is included here. Dr. Ranjan went over some of these already, but we treat commonly primary brain tumors, including glioblastoma, which is the most common primary brain tumor. We also treat low-grade gliomas, which include astrocytomas and oligodendrogliomas, ependymomas, and other more rare tumors like chordoma. We commonly treat secondary brain tumors, which is another word for brain metastases. So when cancers come from outside the brain and spine and metastasize to the brain, it's a common part of our practice. But also we treat a wide range of benign tumors that are, as Dr. Ranjan mentioned, meningioma being the most common brain tumor, 90% being low grade and slow growing, but often do need treatment. We also treat pituitary tumors, vestibular schwannomas, or another name is acoustic neuromas, as well as other rare tumors like craniopharyngioma and hemangioblastoma. And then lastly, we do also treat non-malignant conditions, including AV malformation. So arteriovenous malformations is a vascular malformation in the brain that can cause intracranial hemorrhage. And oftentimes these are treated with either surgery or an interventional procedure to try and clip or coil the malformation and obliterate it. But in some cases, they're actually not amenable to those types of invasive treatments. And so we use high-dose radiation to try and obliterate those and reduce the risk of bleeding. So we treat the whole range of different types of tumors and conditions. When is radiotherapy utilized? So there's different treatment paradigms depending on the type of tumor, but commonly surgery is the preferred upfront approach, particularly for primary brain tumors or other large tumors that are causing compression. So we'll use radiation after surgery. Sometimes when surgery is not indicated or there's too many targets to go after with surgery, we will treat with radiation instead of surgery as the preferred local modality. And then, of course, we also treat for tumors that might recur or metastatic disease. And then there's also instances where we're not necessarily treating with a more definitive intent, but trying to just relieve symptoms or improve quality of life. And so that's another common utilization of radiotherapy. So as far as the patient experience and what they can expect, when the first step is to meet with your radiation oncologist. In that consultation, you'll review your imaging, your pathology, do a physical exam, and discuss what treatment options there are and what the indications for radiation are. We'll go over the risks and benefits and then make a determination to proceed. Once we've made a decision to initiate radiation, there's a planning process that's involved. And it starts with a CT simulation or a special CT scan that's in the radiation oncology department, where we scan the patient in the position that we want to eventually treat them in, and we use that CT scan as the template to do the radiation mapping. During that time, we do need to mobilize the patient so that we can reproduce that position. We often do that with a thermoplastic mask, which you can see in the figure there. This is like a plastic kind of mesh material that you can see through and breathe through, but lies over the patient's face and molds to their face in order to mobilize them. In some cases, we'll actually also use a metal frame that the neurosurgeon will apply to the outside of the skull and hold the patient still during the treatment. From that point, we will plan the radiation. This is done with many excellent medical professionals who are kind of behind the scenes, called the dosimetrists and the physicists. And this team will generate the radiation plan in treatment planning software, kind of accounting for all the details that the physician lays out, and then presents the plan to the physician for eventual approval. And this process can sometimes take about a week and a half or 2 weeks to complete, depending on the complexity of the treatment. And then eventually the patient would come back for treatment start. So that's the next time the patient would be back in the department. And then treatment would typically look like this. The patient would lie on the treatment table. There would be a radiation machine. This is a linear accelerator that would then move around the patient and deliver the radiation externally. The number of treatments depends on the scenario. Sometimes we can treat in even a single treatment. Sometimes it's more what we call fractionated approach, where you give a little bit of dose every day, and that builds up over time. The effects build up over time in the patient, and allows for the healthy tissues to recover in between the treatment sessions. So the approach will depend on the clinical indication. I'll talk about that in just a bit. In general, the treatments are relatively fast each day, around 30 minutes or so, sometimes a little bit longer, up to an hour, depending on the technique. But most of the time, the patient spends on the table is actually more for positioning and verification. And the actual beam on delivery time typically is on the order of 5 to 7 minutes. So it's actually quite fast. You don't feel anything during treatment. It's a painless procedure. It feels like going to get a scan, where you don't feel anything. There's no anesthesia required, and we don't put any restrictions on patients during the treatment course, typically. And then after you complete the entire radiotherapy course, we do need to continue to follow you and monitor your progress. So we'll continue to get serial imaging and evaluate those results in a multidisciplinary fashion. So what are the different types of radiotherapy? So kind of the bread and butter of radiation therapy is external beam radiotherapy. So this is like the linear accelerator picture I just showed you, where a beam of energy comes from the outside into the patient, is delivered to the tumor. And there's different types of external beam radiotherapy that we utilize, which I'll talk a little bit more in detail. There's 3D conformal treatment, which is kind of more conventional radiation, a simpler planning, faster turnaround time, and we use that for certain situations. Then there's intensity modulated radiotherapy, which is kind of the workhorse of radiotherapy, and this allows us to more conformally shape the radiation dose, and I'll show you some examples of that. Stereotactic radiosurgery. This is similar to IMRT, but is used for more smaller lesions and is more of an ablative treatment, and is an important part of radiation, the radiation tools in our toolbox. And then all of these types of external beam radiation, typically photon or X-ray radiation, again, on that electromagnetic spectrum. We also now at Lynn Cancer Institute have proton therapy, which is an advanced form of radiation that, instead of X-rays, utilizes the proton particle from the nucleus of an atom. We isolate this and speed it up near the speed of light and create a beam of protons. And that beam has different physical properties, different advantages in certain clinical scenarios, which I'll explain more. So those are all the typical types of external beam radiation. We also do radiation using brachytherapy. So this is where you actually have instead of a beam, you actually have a live radioactive source. Sometimes the source will actually look like a grain of rice or like a little piece of metal, but it actually is emitting clinically significant radiation. And we will use this for purposes in the brain, sometimes intraoperatively. So patients will actually be in the OR undergoing neurosurgery, and there are instances where we will actually implant active radiation into the surgical cavity at the time of surgery. So, and then what areas are we treating? So most commonly, we try to focus the radiation just where the tumor is. That's called partial brain radiation. But there are certain scenarios where we actually have to treat more regionally. So we either have to, if the entire brain is involved, sometimes we treat with whole brain radiation. And then there are also instances where if the brain and spine are involved, we will treat using a technique called craniospinal radiation. So many different ways to approach radiotherapy. And before I get into some more details, I just want to make the point that there really have been some amazing advances in the field of radiotherapy, over the last couple decades. Really allowing for more precise and accurate treatment. Part of this has been the use of really fantastic imaging that we rely on to guide radiotherapy planning. So we'll actually take your high resolution MRI scans, sometimes some special PET scans, and we'll actually fuse them with that CT simulation scan in order to most accurately define where the tumor is, where the rest of the normal brain tissue and subsites are. And this allows us to tell the treatment planning system to optimize the radiation dose to where we want to treat it and where we want to treat, and avoid as much as possible the areas that we're trying not to treat. And this has really moved the field forward. In addition, the use of radiosurgery has been a really important next step in radiation therapy, allowing us to more quickly and more effectively ablate tumors in the brain. And I'll show you some examples of that. And then, of course, we now have other advanced radiation modalities like proton therapy, which are really transforming the field of radiation oncology and what we can achieve. And so at Lynn Cancer Institute, we're fortunate to have really the whole range of radiation technologies under one roof. And you can see here a lot of different machines. They all have different functionalities, play a different role. And when you have all these different technologies under one roof, what that enables you to do is really personalize the treatment plan and employ the optimal modality for any given diagnosis. So you really can tailor treatment, to the specific scenario, and it's not a one size fits all approach. So we're fortunate to have this in our arsenal at Lynn Cancer Institute. So getting into the different types of radiation, so 3D conformal radiation, as I mentioned, is kind of the most conventional approach with radiation planning, and is kind of more simple planning based on the 3D CT imaging that we acquire. We place fields, look the direction which we want to bring the beam into the patient, and then we will place blocks around the patient, around that area, in order to spare what we're trying to not treat. So this is an example of whole brain radiation, the entire brain in that blue line, and you have your field here with the multi-leaf collimators coming in to block out part of the face, so we can achieve the radiation dose going to the entire brain while avoiding other parts of the face. We also use this approach for palliative cases where we're just trying to treat a partial part of the brain. Because it's simpler planning, there's a faster turnaround time. And so oftentimes when patients are symptomatic and we really just want to relieve symptoms, we'll use this approach to get the treatment plan done faster. So intensity modulated radiotherapy, or IMRT, again, this is kind of the workhorse of most patients getting brain radiation will have. This is a more advanced form of radiation therapy where we are using multiple different angles and sometimes delivered in an arc fashion around the patient with different arcs. And during the delivery of the radiation, the beam intensity is actually modulated with those multi-leaf collimators. So what this allows you to do, if you think about it, is you're able to shape, because you're able to come in a lot of different angles and adjust the intensity of the beam, you're able to better shape the dose cloud to different shapes, different locations, and really eloquently deliver the dose, where you want the high dose to be, and the dose can fall off very quickly beyond the target. And so this technique does take longer to plan, so usually does take a couple weeks from simulation to treatment start. But is what most patients would go through when they're receiving brain radiation. Typically, when in this fashion, we'll give a little bit of dose every day, and it's more commonly delivered over a fractionated course of around 5 or 6 weeks of treatment, coming in once a day. This is particularly useful for larger target volumes or oddly shaped volumes, and again allows for that dose cloud to be conformed or shaped around the target and really carved away from the critical structures that we want to avoid with radiation. We deliver this with millimeter accuracy, so we do allow a couple millimeters for setup error, but in general is a very, very accurate treatment and we use image guidance to ensure that we're in the right location every time. And so this would be the typical treatment for glioblastoma, or sometimes we use this technique for a regional treatment like whole brain radiation when we're trying to avoid certain areas. This is a technique called hippocampal avoidance whole brain, and I'll show you an example of that in a later slide. This is the NCCN guidelines showing the workflow for treatment of a glioblastoma. So we always, in this scenario, we always start with maximally safe resection, trying to debulk the tumor as much as possible or remove all the gross disease that we can see. And then once we have the diagnosis of glioblastoma, if you see here the paradigm indicated for radiation therapy, often with concurrent oral chemotherapy that Dr. Ranjan would prescribe. The next technique to discuss is stereotactic radiosurgery. So this is similar to IMRT in that it's a highly conformal treatment. The dose is modulated, and it can be, the dose can be very conformal to the tumor we're trying to treat. The difference is that the approach is different in that we try to increase, we give a very high dose typically in each treatment. And the intent isn't so much for the effects to build up over time in that fractionated regimen, but to really be an ablative treatment, sometimes even a single treatment, but up to 5 treatments. And so the dose is very, very high on each treatment day, and it has a different, overall effect on the tumor cells because of that. And we often will allow the center of the target to get very hot with dose in order to be even more effective. And the way that we deliver this is similar to IMRT in that we use a lot of different beam angles, but it's even kind of amplified in that we're really trying to be as sharp as possible with the dose fall off. This is an example from a gamma knife system where you have numerous different sources around the patient. that all focus at one point. So it's like if you took 100 flashlights and put them in a circle, and all the beams converge on a single point, and it's very bright in the middle. And that's how we're able to put a very high dose on the target while the rest of the brain sees a very low dose. And when we do this type of treatment, we're even more accurate with our immobilization and our image guidance, and we have sub-millimeter accuracy for this. So that's why this technique is named radiosurgery, even though it's kind of a misnomer. There's actually no cutting, there's no surgery involved, but it's such a high dose delivered in one or only a few treatments intended to essentially ablate or remove the tumor in that sense. So radiosurgery is particularly useful for small targets. If the target is too large, then it starts to become unsafe to deliver radiosurgery. So this is an example of a patient with numerous brain metastases. You can see they're all relatively small, but when there are this many, you can't remove all of these by surgery. So radiosurgery is employed to try and get local control of all these little lesions while sparing the rest of the brain, and can be very effective for small lesions. In this case, the alternative way to treat this patient would maybe be to give them whole brain radiation, and so using radiosurgery enables us to achieve local control of all these lesions while avoiding a more regional treatment that might have more toxicity. So radiosurgery is commonly used in this example for brain metastases, but also for other types of tumors. Meningiomas and vestibular schwannomas are commonly treated with radiosurgery. And this is the NCCN guidelines pathway for patients with limited number of brain metastases. So once they have diagnosis and confirmed, radiosurgery really is the preferred approach. Surgery is utilized if there's a large lesion that's causing symptoms or compression, but if the patient has many small lesions, then we would jump straight to radiosurgery alone. And then proton therapy, so an exciting modality that we now have available at Lynn Cancer Institute is actually going online this week. What proton therapy is, again, is it's a beam of proton particles that delivers the radiation dose in a different manner. So on this graph, on the x-axis, you have depth in tissue. And then on the y-axis, you have the dose. And what you see in the green figure above is the beam path, and the blue dots are the ionizations, or essentially where the dose is released. And when you speed up protons at to a very high energy level, they can penetrate tissue and are moving so quickly that they don't have time to release their energy. But as they get to a certain depth in tissue, their energy declines, and that probability of ionization increases exponentially. And so what you have is the beam comes in to a certain depth in tissue, and then will start to release all of his energy at one location. And this results in a phenomenon called the Bragg peak. So you can see here as the dose comes in, it's very low, and then reaches a certain point and then peaks, and then actually falls off immediately after that. So what you're doing is you're delivering the dose at depth, and then you're eliminating any exit dose that might be present with X-ray radiation, for example, where you're not really utilizing that it's unnecessary radiation that exits throughout the rest of the patient body. And so proton therapy can eliminate that exit dose. And so what that looks like in the treatment planning system here, this is a comparison of a photon plan versus a proton plan for a primary brain tumor. On the right, you see the photon plan. The red prescription dose is still very tight and conformal around the target, but you're seeing that exit dose releasing moderate or low dose radiation to the rest of the normal brain in the green and the blue color wash respectively. And when we use proton therapy, it still conforms the dose, but it eliminates that unnecessary spread to the rest of the brain. So this is a major advance, and in certain clinical scenarios can have a really big impact on patient survivorship and quality of life. It's a very different technology. So this is an images from our own installation. If you've been to the Cancer Center recently, you've seen that we have a brand new addition with a large building right next to the lobby, and that's where the Proton Center is housed. It's a very high capital technology, and so there's a large gantry that rotates around the patient and directs the proton beam. And then there's a large cyclotron, which is the device that actually speeds up the protons into to form the beam. Each of these weigh over 50 tons each. And as you can imagine, it's a very costly operation. And so it takes a lot, much more complex technology in order to deliver this type of treatment. So we're fortunate to have this now at Lynn Cancer Institute. Proton therapy can be particularly beneficial for larger tumors, and then certain patients may benefit more than others with proton therapy. So in general, if you're trying to limit late effects of radiation, patients who are either younger or have a more favorable prognosis in their diagnosis are more likely to benefit from the cost savings of proton therapy. And so those are the patients that when you meet with your radiation oncologist, we'll discuss, if proton therapy is really, right for your diagnosis. Another scenario that is very apt for proton therapy is retreatments after you've received prior radiotherapy. So some patients do undergo a course of radiation and then either have a new diagnosis or have tumor recurrence and might benefit from a second course of radiation. This can be, a more challenging scenario because the body does remember the radiation that you previously received, and the risk of toxicities can increase in this type of scenario. So when proton therapy is employed, what we're able to do is when we overlay the prior radiation with the current plan, we're able to know exactly where all the radiation will have been and where it's going to go. And when we use proton therapy in this type of scenario, it can really benefit by eliminating any unnecessary overlap of radiation with the current plan compared to the prior plan. So this is how we integrate prior imaging, prior radiation planning into a current plan and try to fully account for what the patient has previously received. And so again, proton therapy can be most beneficial for certain types of low-grade gliomas that have a slower disease course, and patients are expected to live many more years, and as well as other challenging scenarios like base of skull meningiomas, which are very close to certain critical structures. We're able to better spare around those critical structures. And then the scenario of reirradiation, again, is a growing indication. We're seeing more patients who are coming back or might have lived longer in their disease course and now need second radiation. And so proton therapy is very apt for this application. This is the NCCN workflow for low-grade glioma. So once you have this diagnosis, you can see here that radiation is indicated, and in those scenarios, the statement is consider proton therapy for patients with good long-term prognosis to better spare uninvolved brain. And so this is NCCN recommended for certain types of favorable prognoses. Another approach, I had mentioned this before, is called craniospinal radiation. And so this is a technique where we have to treat the entire neural axis. So the brain and spine are either involved or at risk. Sometimes we use this approach in a curative intent for a diagnosis, for example, like medulloblastoma. Sometimes this can be in a scenario where patients have essentially disseminated brain metastases that not just are in the brain, but actually coat the fluid of the brain and spine. And this is called leptomeningeal disease. And typically, when we're treating this regional approach, that the risks of side effects, because you're treating such a large area of radiation, have been of a concern. And particularly when using older techniques like 3D conformal, which is what's shown in this middle image here. So you have posterior fields coming to the spine and the brain. And when you treat with 3D conformal radiation, you can see here that the red prescription dose is still hugging the brain and spine as we would want, but there is exit dose through the entire body. And you can see that moderate green dose, throughout the heart, the lungs, the liver, the GI tract. And so, oftentimes this type of treatment can be, kind of overwhelming for patients or lead to unanticipated toxicities. And so with proton therapy, if you watch the color wash figure on the right, with proton therapy, you're using posterior beams, but those beams stop at the end of the brain and spine. And so what you see here is you can pull back that dose basically and eliminate that unnecessary spread to all the visceral organs and anterior part of the body, and really help drive down the risk of side effects from this type of approach. So, craniospinal radiation is an important technique that we have, and proton therapy really helps facilitate safer delivery of CSI. And this is the NCCN guideline workflow for leptomeningeal disease. So if patients do have indication for radiation, then it says consider craniospinal radiation in certain scenarios. And when we do use it, we like to we prefer using proton therapy if possible. And then lastly, I did mention brachytherapy. So this is the intracavitary implant of live radioactive sources. The most common radioactive source that we use in the brain is cesium-131. These radioactive sources come in these little padded tiles that are then implanted at the time of surgery into the surgical cavity. You see on the figure on the right, you see these tiles being placed into the brain space. And this can be very useful because the radiation is delivered just locally. There's a very sharp fall off beyond these the padded tiles that enables the radiation dose just to be delivered around the cavity and essentially deliver no dose or very minimal dose to the rest of the surrounding brain. Really the kind of the most precise radiation delivery you can have. Of course, it's more invasive because it's at the time of surgery. And then in this case, the radiation is live. So you actually do go home radioactive from this type of treatment. And you have precautions that you have to take for a certain number of days, depending on the half-life of the source, until the source can fully decay and become inert. And so it's a little more involved, but it can be a very useful tool, in certain scenarios. And so, for example, if a patient has brain metastases and they receive radiation, stereotactic radiosurgery for lesions, and then a lesion recurs or progresses through that treatment, this is a really useful tool to enable a full resection and another application of radiation in the most safe way possible, and evidence has shown that it has a very high chance of local control in this type of scenario. So how do we choose the right radiation approach? Well, this is why it's important to meet with your radiation oncologist and discuss this. And there's numerous factors that we take into account when trying to decide which machine, which approach is best for the particular clinical scenario. We'll take into account what the tumor diagnosis is, the size and location, what the patient's age and overall health is, including their overall prognosis. we definitely take into account prior treatments. So if they've had prior radiation, it's a very important consideration, and then what their symptoms and ultimate goals of care are. Next, I'll talk quickly about the side effects of brain radiation. So there's short-term and long-term side effects. In general, when patients are going through radiation, they tolerate this type of treatment very well. The most common side effect is fatigue, and patients can experience this more towards the end of treatment. We also do see hair loss when we treat with radiation around the brain, but it's more of a partial hair loss depending on the location, and this is more commonly seen if the target is superficial near the scalp. And so the skin will see in certain areas enough dose to cause hair to fall out, but typically it is temporary. And then we also monitor for other side effects like nausea or headaches, which are typically which are caused by kind of temporary inflammation from the radiation, are typically well tolerated. And then long-term effects. These are really the effects that are more substantial or more likely to affect patients' quality of life. These effects can occur months or even years after you finish radiation, so it is important to continue follow-up. The most kind of concerning late effect of any radiation around the brain is memory or cognitive changes, which we can see over time to some degree, depending on the patient's baseline cognitive status. And so, there's techniques that we try to employ, like proton therapy, that we utilize to try and minimize these effects. We can also cause late edema, or what's called radiation necrosis, which is swelling in the brain, just like if you hit your knee and you have a bruise on your knee. When we hit the tumor, sometimes there can be swelling or bruising in the brain, and sometimes we need to use certain medications to help manage this type of edema. And then, depending on the location of where we're treating, there are potential risks, but small risks of injuring nerves that might be involved with vision or hearing. We can affect the pituitary gland function. Sometimes patients might need supplementation. And then when we use radiation anywhere in the body, but in the brain, we can, in some rare cases, see secondary malignancies, or essentially the radiation inducing a second tumor. This is uncommon and typically does take decades to develop if it does occur. So it's something that we're aware of, but usually the benefit of treatment outweighs this risk. This is discussing how we try to minimize the cognitive changes of radiation. So we know now that there's not just one location in the brain that's critical for memory formation, and certain parts of the brain are more eloquent for this than others, like the hippocampus or the corpus callosum or intrahemispheric white matter tracts. And we know now that if we avoid certain areas with our radiation planning, that this can reduce the risk of or the effects of cognitive changes over time. And so, for example, when we deliver whole brain radiation, there's now a technique called hippocampal sparing or hippocampal avoidance whole brain radiation, where we still treat the entire brain in that prescription dose red, but we actually will delineate and cool down the plan around those eloquent areas like the hippocampus, which in studies have shown that this does reduce the late effects of cognitive changes on patients. And then lastly, how do we monitor patients after radiation treatment? How do we know the treatment was successful? And really, time will tell. We need to continue to monitor patients after they receive radiation, typically with serial imaging and physical exam, and confirm that the tumor is responding. This is an example of a lesion on the kind of right parietal region. After radiation, you can see it's very nicely shrunk down. We love to see this result, but even if the tumor doesn't necessarily shrink, if it's stable, then that's still considered a treatment success because tumors should grow over time. But this is a very easy example of a good outcome. Sometimes it's not so clear. Sometimes we'll treat with radiation, and then there will be, as you see in this middle the figure on the right, there will be some treatment changes. Sometimes the lesion, the enhancement will actually look larger or more hazy because there is inflammation in that area, and it can be difficult to discern if this is, truly disease progression or if this is just radiation effect or edema. And in these scenarios, it can be challenging to determine. Sometimes time is needed to allow it to declare itself, but we'll also employ additional advanced imaging techniques like certain types of PET scans or MR perfusion, which assess different characteristics around in the brain that can help inform us, whether this is looking more like radiation necrosis or more like tumor recurrence. And so we use these advanced imaging to help guide, clinical management after you've received radiation. And then sometimes, if it's still unclear or the patient's having symptoms, we might need to get tissue. So there's instances where we'll do a stereotactic biopsy or even a resection of this area to confirm, to one, reduce the symptoms, but then also confirm whether there's viable tumor. So in conclusion, hope I made the point, radiation therapy is a cornerstone of brain tumor treatment. The radiation technology has really improved both in precision and safety in the different types of approaches we have to employ. The treatment approach is truly individualized given the individual patient scenario. And it really is a multidisciplinary approach. Even after we deliver radiation, we still need to work with our neuro-oncology and neurosurgery colleagues in the management of these patients, and it's really a big team effort. And then long-term imaging surveillance really is needed after radiation to monitor for treatment response. So with that, I will stop and thank you for your time and attention.
Thank you both. Let's see if we have any questions or anything in the chat box. I have to say, it's been a while since we've been able to provide education on brain cancer. So we're very grateful to the two physicians we can appreciate how much time goes into not only the research on this, but putting everything together to provide such comprehensive education. So thank you both. You both did an amazing job, and we're very grateful. And yes, somebody just said, thank you for all of this information. We should do more of this. Yeah, and like I said, we haven't had presentation on brain cancer in a while. So this was very, very good for our patients and for our community. We're very grateful. And to everyone that's on the presentation, this was recorded. So if you want to go back and review any of the education, or if you have someone that you'd like to share it with, when Lee sends out the evaluation, we always appreciate you completing the evaluations, but at that time, you can also ask us if you would like to have a copy of the presentation, and Lee will send you the link. Our next presentation will be actually on this Friday, along with May being Gray May for Brain Cancer Month. It's also Skin Cancer Awareness Month. So on Friday, we will have our presentation on skin cancers, and our presenters will be Dr. Ann Reed from the Rendon Center, a dermatologist in Boca, Dr. Harold Huss, a surgical oncologist, and Dr. Anurag Agarwal, radiation oncology, both of them here at the Lynn Cancer Institute. So thank you to our amazing speakers, and thank you to everyone that joined us on your lunch hour today. Hope we'll see you on Friday. Okay. Good. Bye-bye. Oh, wait, there's one more thing.
Thank you. It was a pleasure.
Oh, just comments on thank you. So you're getting a lot of thank yous.
Thank you so much.
Bye-bye.